I will talk about simplifying testing and treatment experience from Swiss opioid agonist therapy programs, including pharmacies. Before we start talking about simplifying testing and treatment, we should have a look at the barriers to diagnosis and treatment and possible solutions. We have to deal with a hard-to-reach population, people who use drugs, opioid agonist therapy patients, migrants, prisoners, and we should go to where the patients are and think outside the clinic. There's lack of awareness and knowledge among patients and healthcare providers, and this needs patient and provider education. Stigma, including self-stigma, is another barrier, and on-site testing and treatment and opt-out screening would be a solution. Difficult venous access after long-term intravenous drug use is a barrier, but nowadays we have diagnostic tests using saliva or capillary blood, which are helpful. In case of a referral to a specialist, people who use drugs often have difficulties keeping appointments. After repeated no-show, they don't get another appointment, and in the end, no treatment. Again, on-site testing and treatment, telemedical approaches like HEP care, integrated care, patient navigation, and coordination are useful. Long waiting times for a specialist appointment and long turnaround times for laboratory tests, for instance, 1 to 2 weeks for an HCV RNA, make a test and treat vaccinate approach not possible. And we have a high risk of loss to follow-up. The EASL guidelines from 2020 recommend rapid point-of-care tests, reflex RNA, and HCV core antigen testing if HCV antibody positive. And in case of a positive screening test, we often need another venous blood draw for PCR. And we should aim at a single visit diagnosis using point-of-care tests and reflex testing. So this slide shows how opioid agonist therapy works in Switzerland. There is an estimated 22 to 27 people with opioid dependency in Switzerland. About 80% are in an opioid agonist therapy. 16,000 receive either methadone, buprenorphine, slow-release morphine, or levomethadone, and this is approved by the cantonal physician. And another 1,700 people are in a heroin program, and this is regulated on the national level by the Federal Office of Public Health. Prescription of heroin is restricted to 23 institutions in 14 cantons in Switzerland. In contrast, all the other opioid agonist therapies can be prescribed by any physician. Accordingly, in 60% OAT is prescribed by the general practitioner. However, the place where patients are seen at least once a week is the OAT provider, and this is in 51% the pharmacy, in 33% an institution, and only in 14% the treating physician. There are cantonal differences. In the Canton Aargau, almost 80% the OAT provider is a pharmacy, and the institution is the OAT provider in 20%. The frequency of appearance is in half of the population once a week. The rest comes more frequent. And another number of interest is that the proportion of OAT patients with ongoing intravenous drug use is around 27%. Now I will describe 3 projects in the Canton Aargau to simplify testing and treatment. In 2013, we started the Agovian OAT cohort, which is also part of the nationwide Swiss Association for the Medical Management in Substance User cohort. And in 2011, telaprevir and boceprevir, the first generation direct-acting antivirals, which had to be given with pegylated interferon and ribavirin, were available for genotype 1. But less toxic interferon-free DAA treatments were on the horizon. We have in the Canton Aargau a mostly decentralized setting. 631 OAT patients are cared for by 161 OAT prescribers, which makes an average 4 OAT patients per physician. And it has been shown that low caseload is associated with low knowledge. And for GPs, HCV is a kind of orphan disease compared to upper respiratory tract infections and hypertension, which is their daily business. We offered free HIV/HCV rapid point of care test with capillary blood performed by the OAT prescriber and non-invasive liver fibrosis assessment with mobile fibroscan performed by the study team. The proportion never HIV screened went down from 26% to 2%. There were no new HIV diagnoses. The proportion never HCV screened was reduced from 24% to 2%. And we have detected 40 new HCV diagnoses, but also had 10 false negative results, but all were HCV RNA negative and thus neither infectious nor in need of treatment. And the proportion of chronic hepatitis C patients lacking liver fibrosis assessment was reduced from 52% to 2%. But we had persisting gaps. 19% of the HCV antibody positive patients had no HCV RNA test, and 54% of the patients developing chronic HCV infection were never treated. In 2018, we started the HCV elimination program in the heroin program of the Canton Aargau. Since 2017, pan-genotypic DAAs were reimbursed in Switzerland irrespective of liver fibrosis stage, but they had to be prescribed by an infectious disease specialist, a gastroenterologist, or an addiction specialist with experience in HCV treatment. And none of them was present in the psychiatrically led heroin program. So we are now in a centralized setting. Every 4 weeks, an infectious disease specialist and a study nurse visited the heroin program, offering HIV and HCV antibody rapid testing and rapid point of care HCV RNA quantification with a gene expert from capillary blood and fibroscan and HCV treatments prescription on site. What were the results? The proportion ever HCV antibody tested went up from 83% to 93%. The proportion of HCV antibody positive patients ever HCV RNA tested increased from 89% to 98%. The proportion of HCV antibody negative patients with recent test, that is not older than 1 year, increased from 28% to 87%. And for the HCV antibody positive RNA negative patients, the proportion with a recent test increased from 50% to 92%. And treatment uptake increased from 60% to 92%. And at the same time, HCV RNA prevalence among the HCV antibody positive patients decreased from 38% to 7%. But there was still persisting gaps. Rapid point of care HCV RNA quantification with capillary blood requires a mobile but expensive analyzer, which restricts its use to a centralized setting. So this year we started an HCV elimination program in decentralized setting in pharmacies. In between, the Federal Office of Public Health published guidelines for drug users. They recommend HIV, hepatitis C, A, and B screening for all people who use drugs, HCV treatment if chronic hepatitis C is detected, and a yearly HIV/HCV antibody or HCV RNA screening if negative, and hepatitis A/B vaccinations if they are not immune. Since 2022, there is no DAA prescriber restriction anymore, and DAAs are also separately reimbursed for inpatients. In between, we also established HCV RNA quantification from capillary dry blood spots with an expert HCV viral load test, the gene expert. And the cantonal physician has agreed that pharmacies can vaccinate against hepatitis A and B on individual prescription. So now the pharmacists can offer their OAT patients capillary HIV, HCV, and hepatitis A/B antibody rapid testing, HCV RNA quantification from capillary dried blood spots, and HCV treatment and hepatitis A/B vaccination on site. So the first pharmacy with 4 OAT patients started in October, and I presented preliminary results. 9 patients had already adequate HCV management. They were either HCV antibody negative and had a recent test, or HCV antibody positive, RNA negative, and had a recent HCV RNA test. Among them was a couple only recently treated for HCV in close collaboration with the pharmacy due to a repeated no-show at the infectious disease outpatient clinic. 5 patients already left the pharmacy, and among the 30 remaining patients, 19 were approached so far, and 68%, 13 of them agreed to be tested. None of the 13 HIV antibody, 10 HCV antibody, 3 HCV RNA tests in dried blood spot were positive, but we had 2 positive results for the hepatitis A rapid test. So our preliminary conclusion is that rapid point-of-care tests with capillary blood and dried blood spot sampling is feasible in Swiss pharmacies. So which problems are solved? We now have HCV antibody testing with rapid point-of-care tests with either cellular or capillary blood. For HCV RNA testing, we have also rapid point-of-care tests or dried blood spot with a gene expert. We don't have to wait 6 months before diagnosing chronic hepatitis C. If there is an HCV RNA decrease of less than 2 logs within 4 weeks, this is sufficient to diagnose chronic infection. Genotyping is dispensable with the use of pan-genotypic DAAs. There are no liver fibrosis or prescriber restrictions anymore. For liver fibrosis staging, we can use either FibroScan or UPRIC score. Treatment, we have in Switzerland 2 options, either once daily 1 tablet for 12 weeks or once daily 3 tablets for 8 weeks. For treatment monitoring, if we have high suspicion of loss to follow-up, SVR4 can replace SVR12. Adherence is approved due to better tolerable all-oral treatments and shorter treatment duration, and the pan-genotypic DAA treatments are more forgiving than initially thought. Treatment success is greater than 95% and reinfection is low. However, there are persistent problems and unmet needs. Hepatitis rapid tests, HCV core antigen, and hepatitis D RNA are not reimbursed in Switzerland. Reflex testing for HCV RNA or HCV core antigen is not established in Switzerland. Dried blood spot testing or plasma separation card testing is currently not established in Switzerland on the national levels, although EASL guidelines recommend to do so. The risk-based screening is not fully implemented, and although less stigmatizing opt-out screening is not established, there is no hepatitis C registry in Switzerland and no possibility to document the HIV, hepatitis C, hepatitis A/B status of opioid agonist therapy patients in the existing platform, which would be helpful for the yearly screening. And although Swiss general practitioners and psychiatrists are now allowed to prescribe DAAs, they rather refer patients to a specialist and don't make use of the telemedical option HepCare. Since 2020, the combined hepatitis A/B vaccination Twinrix is not reimbursed anymore in Switzerland. And babies are only vaccinated against hepatitis B since 2019, and since 2098, 11 to 15-year-old adolescents are vaccinated, but people born before 1983 are not systematically vaccinated. So far, there is no reliable rapid point-of-care test for anti-HBs and anti-HBC, but this would be desirable for a test and vaccinate approach. Pharmacists are currently not reimbursed for performing rapid point-of-care tests concerning hepatitis and HIV, and for sampling finger-stick whole blood on dried blood spots or plasma separation cards, and for vaccinating against hepatitis A and B. And there are cantonal differences regarding the vaccinations pharmacists are allowed to perform. So this is a picture of the prison in Lenzburg. Many opioid agonist therapy patients are once in their life in a prison, and I want to hand over to Claude Scheidegger, who talks about simplifying testing and treatment in prisons.